Calcium oxalate crystals, which look like grains of sand, come together to form kidney stones. These stones can inflict severe pain. Now imagine having to deal with recurrent kidney stones, which could be a sign of multiple genetic disorders that go undetected for years. One of these genetic conditions is called primary hyperoxaluria, or PH. Primary hyperoxaluria is a family of rare autosomal recessive disorders in which the liver overproduces oxalate, an end product of metabolism in humans that has no known benefit. Oxalate is normally excreted by the kidneys. Then what happens differently in people with PH? Well, the genetic mutations lead to certain enzyme deficiencies in the hepatocyte, causing overproduction of oxalate. There are three known types of PH: PH1, PH2, and PH3, which are caused by one of three different mutations. As a result, the breakdown of glyoxylate is disrupted. Glyoxylate then starts to build up in the cell's cytoplasm. Regardless of the pH type, excess glyoxylate is broken down into oxalate by the hepatic enzyme LDH. A therapy that targets LDH can inhibit oxalate overproduction in all pH types. The overproduced oxalate then travels to the kidneys, where it is normally filtered along with other waste and harmful products. When excess oxalate accumulates, it starts to bind with calcium, forming calcium oxalate crystals. These crystals may clump together to form kidney stones, also known as nephrolithiasis. The stones can cause obstructions in the kidneys, the urinary tract, and the bladder. Multiple surgical interventions, which can cause damage to the kidneys, may be required to remove stones. Calcium oxalate crystals can also cause nephrocalcinosis, or calcification of the kidney. Calcification causes kidney damage, infection, and inflammation, and reduces the kidney's filtering ability, leading to a decline in renal function. If untreated, this can lead to chronic kidney disease and eventually end-stage renal disease, which may require dialysis and a dual liver-kidney transplant. Systemic oxalosis will begin when glomerular filtration rate drops below 35 to 40 mL per minute. In systemic oxalosis, the excess calcium oxalate that cannot be filtered by the kidneys escapes and starts to deposit in the tissues of the skin, heart, eyes, and skeleton. Early diagnosis, along with aggressive supportive treatment, can reduce the formation of new kidney stones and slow the progression to end-stage renal disease and systemic oxalosis. There are ongoing efforts to develop treatments that, if approved, will address the overproduction of oxalate by hepatic LDH, which drives the progression of PH.